Hi, I'm Jack Farr. I'm here with Brian Cole. We're going to talk about how we've changed our thought process on cartilage algorithms over the past 20 years. Brian, I want to start off about small lesions. Have things changed much?
I think they have because, well, the first thing that's interesting is that if you look at sort of clinical adoption, small lesions are often not treated that aggressively. So the good news is I think that people tolerate small lesions incredibly well. So
why don't we define small? To us, small is a little different to somebody else.
So I think the thing that's interesting is that we talk about size, but size is often dictated by how relevant they are and often by the technology that we have available to us. So we've typically tried to say, well, these are 1 to 2 square centimeters, that's sort of our small range. 2 to 4 square centimeters is our intermediate range, and greater than 4 is our large range. Embedded in that concept, though, is our outcomes. In other words, small lesions, if they do hurt, they are often amenable to sometimes very simple things. Even debridement can remedy some of these individuals to be less or asymptomatic for periods of time, whereas that may not be effective for intermediate-sized lesions. And intermediate-sized lesions, as you approach, say, 4 to 6, may not do as well with marrow stimulation and so forth. So it's very difficult to just drop them into buckets, but suffice it to say, if we want to have an overview to help guide people on how to think about managing these lesions, I think we can at least use that as a discussion point, small, medium, and large.
I think something we've been talking about for the last 10 years is size. Absolute size is important, but relative size and how much of the actual condyle, for example, if you have a ballerina with a, quote, size 1 femur and you have me with a size 6, 10 millimeter lesion is going to be much different on her.
Yeah, absolutely. And we have some really interesting research that looks at how these can be load shielded. The small lesion relative to a small condyle, as you're saying, is a lot different than a large lesion relative to the same size condyle, which is why they tolerate it. And we basically see the more normal cartilage they have remaining relative to the size of the defect that may manifest in how load bearing leads to the onset of symptoms or the absence of symptoms.
So I think for me, a small lesion, I have to respect them. And if I find it incidentally, then I think to treat it is somewhat overly aggressive in most cases. So most of those small lesions, so maybe less than 1.5 centimeter, I'm going to evaluate them, stabilize the margins, take away anything that could be a mechanical irritant, but then basically just measure it and grade it and observe the patient. Many of these people will become asymptomatic with short duration.
I would agree. So what you alluded to is the relatively asymptomatic or incidental lesion that may have a very innocuous natural history. Most of us who see a number of these patients will tend to just stabilize them and watch them going forward, sort of benign neglect.
So those that do become symptomatic, say 1.5 to 2 centimeters, what's your personal algorithm?
So I think there are several options, and obviously there's other nuances, athletes in season, so forth, mechanical symptoms. If you have that rare patient, that one you can still treat the same way you just described and render them less or asymptomatic. But definitive treatment, I think, ranges from either an osteochondral autograft, maybe in our more higher demand level patient, which has excellent outcomes when you look at return to sport, versus microfracture or marrow stimulation. And I think advances that we've had there allow us to treat those lesions pretty predictably, and I'll typically use as an adjunct anything bigger than 1.5 square centimeters. I'll typically add BioCartilage to that as well. But I would suffice to say the buckets for small lesions, if I'm not going to simply debride them, will either be for their intermediate to high level patient, marrow stimulation adjunct BioCartilage with ACP, or osteochondral autograft if it's a very high level individual who has an 11 millimeter defect or smaller in circumference, because I prefer to use a small number, maybe just one osteochondral autograft plug.
Yeah, I think the literature looks fantastic for osteochondral autograft for the small lesions, the return to sport, the early return to sport. But for me, it's hard to find those small lesions that are symptomatic.
I agree.
I think you touched on another point on an in-season athlete, or maybe they're trying to get ready for next year. The Andrews group came out and they showed their results much better with just simple stabilization chondroplasty compared to marrow stimulation.
I mean, you generally don't get long-term. If they have been symptomatic once, they often will become symptomatic again if they remain highly active, but it fits within the confines of getting an athlete back to play within their timeline horizon, whether it's a contract or what have you. So it's a great option that doesn't take them out of the sport for any prolonged period of time. Just can't forget about it as a good option.
Well, I think that pretty well summarizes my thoughts on small lesions. Do you have any other thing to add? Very good. Ryan, that was great.
Thank you.
Thank you.